Hi, everyone, and welcome to OT Echo. It is August 14th, 2025. My name is Kate Barlow, and I'm going to be the host for today's meeting. And I am so excited to present my dear friend, Dr. Jeanne Zobel-Lachiusa is here to talk about sensory integration. Today's meeting is going to be the first half an hour will be a presentation by Jeanne, and then we will have a case study from 2:30 to 2:35. Then we will go into breakout rooms. Adonis is going to help us with that. And then we'll all come back as a large group for the last 10 minutes to discuss our findings on the case studies. If you all could keep yourselves on mute, but feel free to put any questions you have in the chat, and I'll interrupt Jeanne to ask your questions as they come about. So thank you all so much for dedicating your time to be here today. And Jeanne, thank you. Please take it away.
Okay, well, thank you, Kate. Thanks so much for the invitation. I'm honored to be here. This is, a passion of mine, and I want to. I'm looking forward to a discussion with all of you, and I wanted to let you know that I have been an OT for many years, more than I'd like to admit to. And I had the honor and privilege of training at the Ayers Clinic when I was at the University of Southern California back in the mid 80s. Dr. Ayers was still alive and lecturing, retired, but lecturing. And I actually had the honor of also attending her memorial service when she passed in 1989. And I was pregnant with our first child. And I remember being at her service thinking how grateful I am for her work, because not only did she influence us occupational therapists, but she also influenced the way I was parenting. Here's a quick 30-minute presentation, intro to sensory integration, and I'd love to hear your questions as we go along. So the objectives: understand the importance of sensory integration to our field, describe challenging behaviors and health issues and connecting to which area of sensory function, understand the importance of sensory integration assessment prior to implementation of a sensory integrated related treatment plan, compare and contrast sensory integration intervention utilizing remediation versus compensatory techniques. So understand the difference between those two. And I assume that you all saw the pre-test questions. So that's related to these objectives. So sensory integration is actually all of these things. It's a theory. It is actually the first OT theory, because prior to sensory integration, us pediatric OTs were using our theories from the field of education, from psychology. Sensory integration was our first occupational therapy theory, and it's the most well-developed OT theory right now. Sensory integration is also a frame of reference, as you know, guides intervention. Sensory integration assessment, the SI assessment tool that Dr. Ayers developed, and the later on assessment tools were the first standardized assessment, OT assessment tools. Again, prior to that, we were using assessment tools from fields of psychology and education. And also, as you know, sensory integration is an intervention, which is the most research intervention in our field. So it's a theory, frame of reference, assessment, and intervention when we talk about sensory integration. But I want to make sure that we remember where this work came from. So when I first started practicing, again, I know I'm dating myself, back in the mid to late 80s, when I moved back from California to Massachusetts in the United States, I was told in team meetings not to talk about, they called it the S word, not to talk about sensory integration. It was considered kind of fringe, radical, out there, and we were not, at least in the districts that I worked at, it was, people are not open to sensory integration. When I left the districts that I was working in, I just retired from teaching at a little local university in this area. But prior to that, when I was practicing in the schools, when I left the schools, I'm happy to say that sensory integration had become mainstream, like so accepted. I just came back from a trip to San Francisco. In the airport, there's sensory rooms. I'm sure you're all familiar in other airports, right? I mean, there are sensory days in the movie houses, in the malls. So people are, it's becoming mainstream. And when I left the districts that I was working at, the teachers at the team meetings, they were requesting sensory related interventions instead of me. So I'm happy that people are getting sensory integration. It's becoming more mainstream. However, I want to make sure that we are true to Dr. Ayers, well, one, that we honor and remember where this work came from, Dr. Jeanne Ayers, and then two, that we are in fact educated ourselves and giving the correct information to people out there. So because sometimes if we don't have up-to-date training, we might be inadvertently providing not the most current up-to-date information. So anyway, so you all know about Dr. Jeanne Ayers because I'm sure you everyone has a basic overview of sensory integration in their undergraduate and early, pre-professional master's degree trainings, right? So anyway, I just want to point out and make sure that we remember where this work came from. And helpful to always go back to the original source. So if you haven't already, go back to her 1979 text. That was the first text that she wrote that was written for more parents and user-friendly language. And the blue text 1972 is a little more technical, but certainly have these resources reviewed. I think that will help you. So just a few facts about OT and using sensory integration, that adequate sensory integration, the reason we care about sensory integration as occupational therapists is that adequate sensory integration is very important for optimal learning, behavior, motor, and physical health. So that's why we care about it. She was considered, again, it was very fringe and very radical back in the 60s and 70s when Dr. Ayers first started practicing and talking about sensory integration, to think about occupational therapists looking at brain function, and also looking at children with learning disabilities. So that was considered like not in our scope of practice. However, she helps us understand that it's important for us to understand the underlying brain function as it relates to occupations. For school-age children, obviously occupations of being a student and being a player and socializing. So sensory integration, Dr. Ayers did not coin that term. That actually came out of the field of neurology, and that was the term used for a neurophysiological cellular process. But Dr. Ayers uses the term sensory integration. The definition that she uses is the organization of sensation for use. And again, this use is that operative word that's important for us occupational therapists. Organization of sensation for use. To understand the importance of underlying sensory integration function to higher level learning and motor and behavior tasks, thinking of going back to your neurology, there are 5 times more afferent or sensory fibers going in than efferent or motor fibers going out. So it's a really important, of course, underlying function needed for motor function and participation in occupations. So if you do not have adequate, optimal sensory input, of course, it's going to impact your motor output. Um, and just a few other random, I think, important concepts to think about with sensory integration. Of course, if you have problems with sensory integration development, it may lead to health and or physical health and or mental health difficulties. So again, thinking about that foundation of sensory integration, if it's not solid, well developed, is going to impact the child's participation in all other occupations. The thing that's confusing or difficult about understanding these children with sensory integration dysfunction is that these children typically look physically fine. It's always an invisible handicap, so they not afforded the sensitivity and the patience maybe of children who have more obvious disabilities. Children who have sensory integration problems may reject sensory and motor challenges that are simple for their peers to complete. So it's going to, of course, impact their play skills, social skills development, and or motor skill development. They may avoid or reject age-appropriate foods, grooming, dressing, sleeping, which may potentially impact physical health. Sensory integration problems are, again, invisible handicap may be misinterpreted and are viewed as behavior or psychological issues. And then children who have unidentified sensory integration problems may have resulting self-esteem and self-confidence issues, which may lead to future mental health challenges. So again, really important for us occupational therapists to help people understand this type of diagnosis and impact on physical and or mental health development. So there's different types of sensory integration disorders. So you can have poor sensory discrimination, like we're familiar with visual discrimination issues, auditory discrimination. You may have poor vestibular related problems. There's what I'm going to be for the next couple slides is just looking at the sensory integration challenge called sensory reactivity type. So children who are either hypersensitive, oversensitive, or hyposensitive, undersensitive to one or more of the sensory systems. And of course, the goal is to have us all and the children we work with functioning in the middle range. We don't want to be too sensitive, or we don't want to be too under responsive because that will impact function. So the goal is to be somewhere in this mid-range. And if, again, this is one of the types of sensory integration challenges, if the child is oversensitive to one or more of the sensory systems, hearing, vision, touch, movement, we can call that, this is the visual that helps me. I like to think of these children as having a little cup that is easily overfilled by sensory input. And so we can talk about that child being either hypersensitive, hyper responsive, you may hear it described as having a low tolerance or a low threshold for one or more of the different types of sensory inputs. And resulting behavior for this child has a little cup, they're easily overfilled, they're easily oversensitive. Some of the behaviors you may notice they may avoid, they may exhibit what we call a fight or flight response. They may be easily irritated or fussy, and just described as difficult to calm. So these are the children who are oversensitive to, again, one or more of the sensory systems. It's like a detective. You are the detective trying to figure out what is the challenge, which sensory system might be impacting function. And then the opposite of that, you might have some children who are under-responsive or undersensitive to one or more of the types of sensory input. They're described as having a high tolerance or a high threshold for sensory input. So I like to think of that as like a child has a really big cup. No matter how much you put in that cup, they still are not going to be um, satisfied. So they're always seeking out extra input. So they're sensory seeking, they're not registering the input. They may be, those children who are under responsive, undersensitive may be perceived as either sluggish or slow moving, maybe slow to warm up or slow to alert to input. So these are just an example of two types of sensory challenges, a child who's oversensitive or a child who might be under responsive or hypo sensitive. And again, Dr. Ayers helped us understand the important foundation that sensory integration provides for higher level function. And she helped us understand that the most basic, this is one of the pretest questions, in case if you didn't remember it. The most basic sensory systems children are born with and are fully developed in utero are vestibular, tactile, and the proprioception sensory system. So these, if all's going well in utero, the children have a child um, in utero has intact vestibular, tactile, and proprioception function. Those lay the foundation for reflexes, for example. These three primary basic sensory systems are described as internal because the input is found within the body or your near or proximal senses, versus the later developing external because the receptors are outside of the body or far senses. And these are, again, if all is going well in utero, at time of birth, vestibular, tactile, and proprioception systems are fully functioning. They lie the foundation for these later maturing systems: visual, auditory, gustatory, taste, olfactory, smell, and tactile, the discriminative tactile system. This tactile system that is fully formed in utero is actually the primitive tactile system that responds to pain and temperature. So it's the protective tactile system. Whereas this tactile system is later developing if all is going well and their child's provided with a wide variety of sensory inputs to help optimize their development, they'll develop discriminative tactile abilities. So, and then these external or far senses lay the foundation for higher level learning behavior, motor planning. Another term for motor planning is praxis skills. So you can see if there's an issue with these three basic early developing sensory systems, it is going to impact these higher level sensory systems, which in turn will impact, of course, learning and behavior. So just again, a little repeat, the sensory systems of primary importance, those proximal senses, because they are derived from within the body. Tactile is the first sensory system to develop fully in utero. Receptors are found in the skin. The skin is the largest sensory organ in the body, and it provides protection. And then later in development, it provides tactile discrimination, which of course is important for fine motor and function. Proprioception, along with the tactile system, comprise what is called the somatosensory system. That's needed for knowing where your body is in space, and those receptors are located within your joints and muscles. And then the vestibular system detects gravity, equilibrium reactions, movement, acceleration and deceleration in all planes of movement. It influences muscle tone, and along with proprioception, allows for balance and coordination. And those receptors are found within the inner ear. So again, important to think about those three primary sensory systems. And then some of again, because the title of this presentation was Sensory Integration, OTs Unique Contribution to Healthcare, helping understand physical health and mental health influences from sensory integration function. The tactile system may be implicated in behavioral and health challenges. So, for example, a child who's aggressive or withdrawn results in behavior and social challenges. And again, because they are perceiving touch, to go back to that sensory reactivity slide, either oversensitive or undersensitive to, in this case, touch input. If they're oversensitive, they may be aggressive and fighting back, lashing out. Or if they're under responsive, they may be withdrawn and have challenges socially from not engaging. Feeding problems, that's a really common for kids with tactile sensitivity to have feeding problems which may result in poor growth and development, obviously impacts health. And then sleeping problems, because discomfort with temperature, bedding, etc., clothing, sleepwear that may, if they're not getting enough sleep, it may impact attention, behavior, and social development. And of course, again, poor tactile function may interfere with grooming, dressing, and toileting. So tactile is, again, super important to think about some of those behaviors and health issues. Proprioception.
Can I interrupt you? There's a question
Sure.
in the chat box.
Okay.
And the question is, do you include an assessment of motor skills and function if the school referral is for sensory? I noticed some providers are only giving a SPM2 or SP2 without commenting on motor skills and function or other areas of function. They are just commenting on what those questionnaires provided.
Awesome. Thank you. That's a really good question. We're going to get in a couple more slides. I'm going to just comment on assessment. Super important that you provide an assessment prior to treatment, whether you're providing treatment such as consultation and compensatory strategies, or whether you're providing direct treatment using air sensory integration intervention. So yes, and because we're occupational therapists, you want to provide a comprehensive occupational therapy evaluation. So we are not sensory integration therapists. So that's one piece of the child's puzzle. So you want to, again, thinking about providing data collection about sensory function, yes, but you also, because we're OTs, you want to collect data through your assessments on motor, play, social skill development, right? So depending on what setting you're working in. So super important, because I really want to make sure that we are clear that we are occupational therapists utilizing sensory integration and assessment, treatment, but we are not sensory integration therapists. So I think that's a great question. So some possible problems with proprioception may contribute to health and or behavior challenges, difficulty gauging how much force to use with playing with toys. So they may be perceived as being too rough by pushing children inadvertently because they can't gauge with how much force to move their body with. Eating challenges may arise because of poor proprioception. They may have a weak suck or poor chewing, which of course will impact growth and development. Poor tool use due to decreased awareness of hands and fingers, and then poor gross motor development. So again, thinking about if your child has some challenges in these areas, motor development, eating, playing, thinking maybe that's part of the puzzle. Again, we're detectives trying to figure out putting the puzzle piece together. So some possible behavior and health challenges that may be due to less than optimal vestibular processing, over or under activity. So the child may be, again, going back to that little slide, remember overactive, restless, or under responsive, kind of sluggish, and that can impact behavior and socially. Or bilateral coordination. Vestibular is related to bilateral coordination, results in fine motor and gross motor challenges. Poor balance and equilibrium. Again, thinking aware that the receptors of vestibular system within your inner ear impacts, balance, right? Equilibrium. Of course, that may impact gross motor development, play, and social skills. Because of the close neurological vestibular ocular connection, challenges with if they have poor vestibular, it may impact vision, which may result in academic and motor challenges, poor reading, ball skills, etc. And then children with sensory integration challenges are at high risk for abuse, as are other of our children that we see who are not typically developing, which is a sad thing to think about, but to be important to be aware of. So going into intervention, there's two ways to think about intervention. You can provide OT treatment using remediation techniques. So you're trying to fix the underlying problem. And so that's using OT, using air sensory integration treatment techniques. And there is very specific criteria for using, being an occupational therapist using air sensory integration treatment techniques. And so the newer way to think about that is the fidelity measure for air sensory integration intervention, being mindful and making sure that you are following these criteria that's identified in this fidelity measure to actually use the treatment technique correctly is important to think about. Many of us use what we call compensatory strategies. And really important, if you are working in the schools and you are providing sensory items, consultation around sensory considerations, you have to make sure that you have provided assessment. And so you in the US might be aware of that Choosing Wisely campaign that AOTA came out with in 2018, talking about how it's important not to use sensory interventions without assessment of sensory function. And to that person's question, again, using just a checklist in isolation without thinking about function in general is not going to be as helpful. But compensatory strategies are providing those, again, after you've identified a child, in fact, does have sensory related challenges, providing those sensory items that are familiar to OTs, those weighted items, alternate seating, movement breaks, fidget items, et cetera. So thinking about remediation versus compensatory. I know we have one more minute. I wanted to put that please look at these links at another point. It's wonderful. This is one to see Jeanne Ayres in action in her clinic. It's really wonderful to see her working with children. And this is just an example of what OT treatment looks like using a sensory integration approach. So it's helpful to see those. Like any specialty area, you need to get further education. If you are interested in feeding and eating, of course, you're going on for continuing education, right? Sensory integration, if you are interested in sensory integration, you need to go on for continuing education. And here's 3 resources to do that. Kate and I just completed this, the Class C training for the new AIRS, the evaluation for AIR sensory integration. A few years back, we did that. So this is a fabulous group to hook up with. Kumar Center in Boston, Massachusetts also has great training opportunities. Star Institute, Lucy Miller was the founder of this in Colorado. So these are 3 starting places. Here's the references, and then here's the case study. Am I on time? Yes, 2:30, right, Kate?
You
Am I
are
supposed to be
doing
reading the case
amazing,
study?
Jean. You're
Okay.
almost
And
like you're a professional presenter. Were you a teacher,
oh, okay.
maybe?
Okay. Well, okay. I'm from New York originally. Any of you people from the US know New Yorkers tend to be very fast talking. So anyway, I apologize if I talk too fast. That's my New York background. Okay, so this is the case study that when you break into breakout rooms, you are going to be thinking about this little guy, Dominique, and you probably have all worked with little kids like this. 8-year-old boy in 2nd grade. He had repeated kindergarten, diagnosed with ADD, hyperactivity type, and learning disability, language-based learning disability with delays in reading and writing. The teacher reports he has difficulty sitting in his chair. He occasionally falls out of his seat. He frequently gets up to sharpen a pencil, get drink of water, passes vision and hearing screening. However, he's unable to copy from the board, follow on the page when reading, and keeping writing within the lines. So when you're in your breakout rooms, I'm going to read a little bit more information about Dominic, but I want you to think about which sensory systems, 1 or more sensory systems, do you think might be a challenge for Dominic? And then you're going to be thinking about some suggestions for teacher and for home. So here's a little bit more description about Dominic. He's clumsy, frequently falls, has difficulty coordinating both sides of his body for ball play, riding a bike, etc. He has trouble getting along with peers. They report he is bossy, cries easily, breaks toys, and plays too roughly, pushing, etc. Parents report that he has a history of frequent ear infections, poor sleeping, picky eater with limited diet, and is small for chronological age. His preferred after-school activities include watching TV, playing video games, and roughhousing with the family dog. He is an only child, does not have children that he plays with. So these are the questions for you to talk about in your breakout rooms. Which sensory systems do you think Dominic may have challenges with? Support this with observations, report a function, link that to the function that was described. Suggest compensatory strategies for school use. Suggest compensatory strategies for home use. And what do you recommend for an OT assessment tool and why? So,
Great. Thank you so much, Jean. Adonis
okay.
is going to put you all in your breakout rooms now. If you can put your camera on when you're in your breakout rooms, that would be great. It really helps with the discussion. Thanks, everyone. Well, welcome back, everyone, from the breakout rooms. I hope you had a lively discussion. We're going to start with the first question. Which sensory system do you think Dominic may have challenges with? And let's start with David. What did your group have to say?
Having some tactile problems, given the fact that he roughhouses, pushes, probably some proprioceptive problems, given the poor eating problems, and some vestibular issues, given the fact that he has frequent falling.
Okay, great. Evidence, did your group have, where's the evidence? I'm trying to find you on the screen. Did your group have anything to add to that?
Yes, we did. We talked about the there could be issues with auditory because of the several ear infection that's in the past, and also vestibular because he has been falling from chairs, unable to stand still. So vestibular, proprioceptive, and auditory.
Great, thank you. All right, we'll move to the next question. Suggest some compensatory, I struggle with that word, sorry, compensatory strategies for school use. Botica, what did your group come up with for that question?
Yes, that in our group, people are talking with that dynamic seating and frequently changing the position. Actually, that madam also in our group is a person as a so swinging, climbing, and activities, and also they suggest some teach parents to support children. Yeah, those are the suggestions.
Great, thank you. Mary, did your group have anything to add to that? Did we lose Mary? Sarah, did your group have anything to add to that?
Great. So to add, I feel like we say well, add and also validating. We talked about some positioning things that we could do to help with tactile and proprioceptive input and attention. That might be, different seated cushions. We also talked. One of the systems we acknowledged was proprioceptive challenges and deficiencies. So outside of movement breaks, other opportunities for activities within the room that are maybe scheduled and proactive, such as pushing things, wall push-ups, activity that are not disruptive, but also, providing that input. We also talked about some tools for handwriting and for the actual fine motor tasks for an 8-year-old. I think I'll stop there for now.
Well, that's
Okay,
great.
thank you, team.
All right, we'll move to the next question. Suggest some strategies for home. So let's go back to you, Badika. What did your group come with for home strategies?
Yeah, we have the more suggestion home strategies. So the people are suggest some use different utensils, adaptive devices, and the sleep training. So we more talk about the sleeping problem with sleeping. So it's due to tactile and vestibular problem. So that the comfortable pajama without tags, weighted blankets, and poor cotton sheet. And also some the pillows, cushions, support for the good sleeping, and they recommend the reading before sleeping, and also discourage watching TV and playing activities may encourage good sleep in the home. The suggest.
I love the sleep routine activities. Those are great.
Mhm.
David, what about your group? Did your group have anything to add?
Some equipment for the home, such as a trampoline or a swing, that could be used to provide sensory input.
Great. Sarah, did your group have anything to add for that one?
We had, I feel like, a few different suggestions. One thing that was at the end of our conversation was about sleep hygiene and our role there. We didn't get into a deeper dive. I don't know if this is the space right now to further dive into that, but sleep hygiene for the 8-year-olds is certainly something that was within our scope and either often either not addressed or not as prioritized for other school-based roles.
That's great. All right, so that last question is, what do you recommend for an OT assessment and why? Evidence, did your group get to that last question?
Yes, ma'am. We talked about the sensory profile too, to identify specific sensory processes, their pattern, and how they impact function at home and also at and in school. Yes, and also clinical observation of the postural control, bilateral control, coordination in neutralist tax, and also social skills assessments to explore the interaction with his peers, the difficulty he has been facing. So social skills assessment is also one. Yes, ma'am.
Great, thank you. Jeanne, did you want to add anything? We only have a few minutes left, so if you want to share your expertise on this question, I think that'd be great. Oh, you're on mute.
Thank you. I love that your group was thinking about clinical observations, because that's super important to supplement standardized assessment tool results with your clinical observations, because that is really where we get a lot of valuable information that helps supplement the standardized assessment tool results, and also really kind of helps us keep saying it's like solving a puzzle or being a detective. Kind of helps add valuable information to help unravel the challenges that the child is presenting with. So that's helpful. But I really want to make sure that we're thinking about, this is a really important area for occupational therapy, as I said, unique to our field. Very important that people go out and get further information and education. So those 3 resources are a starting place. Certainly look at those. Because like I said, any of those specialty areas, feeding and eating, NDT, whatever, you always need extra training beyond your education. So I really can't encourage you enough to do that, because we want to make sure we're providing the most up-to-date information for people that's out there. And I think there's a lot of people who are, like I said, I was in the airport where there are sensory rooms, like people are talking about sensory, making sure that us OTs, we own that, but then we also are really making sure that we are representing the work of Dr. Jeanne Ayers adequately and to the most up-to-date we can. It's a super exciting time to be an OT. Look at all the international people we have even on this call and last night's call. I mean, there's people all around the world now who are occupational therapists and using this information to help the children and people they work with. So I love that about us. Like I said, we've come a long way. When I couldn't talk about the S word in school meetings, and now look where we've come. So I'm really happy that you're all here and furthering your education. So.
Well, thank you so much, Jeanne, for this presentation. That is going to end today's meeting, but I'll stay on to answer a couple of the chat questions.